This is part 2 of Is It All the Same Disease? Okay, this guy right here, his nickname is like Gooby. He's a neurosurgeon who quit being a neurosurgeon. Specifically, he was a spine surgeon. And then he made a video about it, and the video went viral. Last time I checked, it had over 8 million views. In one video, he got more views than I've gotten for all the thousands of videos that I've made. Okay, and so basically he was a spine surgeon, and he noticed a few things about being a spine surgeon that were made him not really want to continue doing spine surgery. Also, I'll show you, here's a book I wrote called Ischemic Spine is the Most Common Cause of Back Pain. Ischemia means lack of blood flow to the spine due to atherosclerosis, diabetes, hypertension, and high-fat diets, okay? How to diagnose and treat. I ended up writing the book about the spine. I was kind of pissed off because the journals wouldn't publish my articles. It was, we were talking about dietary and atherosclerosis effects on spine, because you don't make any money with that. If you operate on the spine, you make money. If you do surgery on the spine, if you inject steroids, you make money. But when you teach the patient to eat a low-fat diet and all this stuff, you don't make money. So they wouldn't publish it. I was pissed off. So I said, "Go screw these guys. I'm sick of dealing with the journal people. I'm just going to write my own books." And so that's what I did. Ischemic spine, most common cause spine. Okay, so anyways, how does that bring us back to Gooby? And by the way, I used to run a spinal injection clinic. I did all that stuff. I did large diameter needle biopsies of the spine for tumors. I did epidural steroids, selective nerve root blocks, all that stuff. I'm pretty familiar with it. Okay, here is Gooby. What does Gooby say? He says that he noticed that a lot of his back pain patients, he would sometimes be really busy, and he would schedule them for the operating room, but he would not be able to take them to the operating room for about, a month or more. And what he noticed was that the patients who were going to the operating room, let's say in 3 or more weeks, if they would eat a low-fat, if they would eat the plant-based diet, they would often get better if they would just walk and eat a plant-based diet. So he's like, gee, the surgeries he was doing, he noticed, didn't seem to really make any significant difference. The patients would just get better on their own if they ate a healthy diet, got their sleep, and walked, and didn't have alcohol, because alcohol drops oxygen delivery to the spine. Tobacco drops oxygen delivery to the spine. Sodium diet, vasoconstriction is going to decrease things. So basically, the patients would usually get better on their own if they would just eat a plant-based diet that was low in sodium and not drink alcohol and smoke cigarettes. So he's like, what the hell am I doing? I'm doing all these fancy, expensive surgeries, and it really doesn't seem to make a difference. Don't get me wrong. There's some patients who really need surgery. If they got a congenitally narrow cervical spinal canal, the cord's being compressed by a small disc osteophyte complex, disc herniation, whatever, bone spur. If some patients really have a tight lumbar canal, cauda equina syndrome, short pedicles, there are indications where they really need the surgery. But what I'm saying is the vast majority of patients don't have all this stuff. So he said, even if you do perfect surgery, the patient may or may not get better. And he just didn't feel like he was accomplishing much, and that's why he quit being a spine surgeon. So what I'm laughing about is, that's what I'm kind of saying, is the most common problem with the spine is the diet. And it relates to all these other spine problems. I'll go into more detail on that. And a lot of these patients could be cured if you just fix their diet and their habits, okay? Here's a normal lumbar spine. This is your lower back. Okay, a spinal segment is 2 adjacent vertebrae with the intervening disc. Here's the abdominal aorta, runs down in front of the spine, gives off lumbar arteries at the mid-height of the vertebral body. Then they have a little twig that goes to the end plate. The end plate is the top and the bottom of the vertebra. And then by diffusion, a little bit of glucose reaches the disc. Okay, and the waste products of the disc are pumped out. The disc is alive. It's not dead. The disc does not have any blood vessels, but it runs on anaerobic glycolysis. And the glucose that reaches the end plate down here, the lower part of the bone, it'll diffuse some of it into the disc. And the waste products from the disc will diffuse back into the venous end of the capillary and be taken away. Walking helps to make this process work. It milks the good stuff into the disc and the bad stuff out of the disc. Okay. So what happens is people get a lot of atherosclerosis in their abdominal aorta, especially on the posterior wall. That will narrow, called stenosis, the medical word for narrow, and occlude the lumbar arteries. And then you get a diminished amount of blood flow to these end plates and to the disc. So the disc will break down. It'll dry out. A disc is like a jelly donut. There's nucleus pulposus, soft stuff in the center, and there's like a steel-belted radial tire. I think I have a picture of that in my next picture or something here. We'll see. Well, first of all, here's a normal MRI. Here's a T1. T1 just means the fluid is dark. By the way, spine MRI, you can think of it like in zoology. There's a animal kingdom, plant kingdom. In MRI, there's two kingdoms. There is T1 kingdom. T1 signal means fluid is dark. T2 signal means fluid is bright. And almost everything in MRI is based on that. Okay, so the dark signal of the fluid here. You look at the spine, looks pretty good. You look at it on this image. This is a T2 image with the fluid is bright. And again, it looks pretty good. There's no tightening of the canal. The disc space heights are intact. Maybe they're a little dried out, a little desiccated. But this is a relatively normal looking spine, let's say, for a 40-year-old. This would be a pretty good spine. Okay, here's what I was talking about a moment ago, was that the outer part of the disc, here it is a disc zone, sort of like in a cross-section. The nucleus pulposus is the soft stuff in the center. The annulus fibrosus is like a steel-belted radial tire around the periphery, and you can get a crack in the annulus fibrosus, and the nucleus pulposus can leak out through it, and then that can bulge backwards. So this would be an annular fissure, a tear in the annulus, the rings, and this would be a disc herniation when it leaks back out. The word is typically now annular fissure rather than annular tear, because tear has an implication of a post-traumatic component, which isn't necessarily the case. It can just happen spontaneously due to lack of blood flow, due to ischemia. And you notice that the disc itself almost looks like a tree stump when you cut a tree stump down with all the rings of the tree, and that's sort of the steel-belted radial tire effect of the annulus fibrosus. Okay, here you can see what are colloquially referred to as disc herniation. So the disc can herniate into the bone. That's called a Schmorl's node when it herniates into the vertebral body. A small disc herniation posteriorly, where it's equal to or less than the height of the disc space itself, that's called a protrusion. When the disc herniation is bigger and it goes above or below the disc space, that's called an extrusion. And these are almost like code words. Protrusion usually means it's a small disc herniation. Extrusion implies it's a bigger disc herniation going up and above, and more likely that surgery is necessary. Okay, these are sort of agreed upon terms that are used in describing spinal findings. Epidural lipomatosis means fat. So there's a dural sac in which the nerve roots sit, and then outside of it you're in the epidural space. Excessive fat in the epidural space is epidural lipomatosis, and that's also caused by obesity and high-fat diet. So you can see what I'm saying here is lack of blood flow to the spine will cause these discs to degenerate, and then you'll start getting more disc herniations. Okay, you'll get more fat accumulation in the spinal canal as well. So it's all bad. Okay, here is a lumbar spine MRI. Can you tell what weight it is? It's a T2 weight because the fluid is bright. And you can see there's a small diffuse disc bulge, maybe even a focal disc herniation right here. You're central because the cord's in the center of the canal and there's no scoliosis. So that would be a small disc protrusion. When you get an abnormal disc space, now you've lost the height of the disc and it's not functioning adequately to stabilize the VB above and below. So you're going to have segmental instability, abnormal motion. The disc, has one trick. It confuses itself. Like Ralph Waldo Emerson said in the 1800s, hedgehog has one trick, but it's the best trick. And the spine is only one trick. It can lay down bone and fuse the adjacent bones. And it does that spontaneously when there is a failed disc. And then one disc fails, now there's increased pressure on the adjacent disc, so it will fail subsequently. And these bone spurs will grow all the way from the pelvis, the sacrum, all the way up to the skull. And that's called DISH. DISH means diffuse idiopathic skeletal hyperostosis. This was a graveyard in Europe. And what they found was when they dug up some of these graveyards for construction purposes, the graveyards where the peasants were buried, they had relatively normal looking spines. But where the aristocrats were buried, they had lots of dish on their spine because it's the same thing, because they were eating a lot more meat. So they would have higher fat diets, and they would get, and also clergymen amongst the aristocrats, they'd have a lot more dish in their spines. Because dish is associated with obesity, diabetes, all these Western diseases. So here's these bones that are fused together. Normally they should be separate. Here you can see the intervening disc space, but when they're fused together, that's a sign of dish. Diffuse idiopathic skeletal hyperostosis. So here's a typical end-stage spine. By the way, I see these all day long, every day. They're so common, it's not even funny. This is just a typical old guy spine. You have interbody fusion at some levels where the vertebral bodies are fusing. you'll have dish, anterior vertebral body bridging osteophytes going all the way up and down from the sacrum, pelvis, all the way up to the skull base. You'll sometimes calcify, ossify the posterior margin of the disc. That's called OPLL, ossification of the posterior longitudinal ligament. And I used to read things in the books back in the 1990s. OPLL is a very rare condition, more common in persons of Asian descent. And that's total BS. I see it all day long, every day in Western patients. Okay. Here's a patient who fell and got what is called a chalk stick fracture. So the bottom line is when you have these anterior bridging osteophytes of dish, they, in a sense, produce what is called stress shielding. You'll notice there's relatively loose in anterior vertebral bodies because they're not bearing weight. They don't mineralize as well. So that's called stress shielding, meaning that bone is very soft. And if a person falls down, they get a fracture plane of force that gets in between these bridging osteophytes. It can cut right through the vertebra and snap it like a twig. So that's called a chalk stick fracture. It snaps like a twig. You can see there's some ossification here across the disc space. So that's inter-body fusion. You're fusing the two vertebral bodies. You can see there's ossification across the posterior disc margin. So that's real early OPLL. Here it is again, ossification across the posterior disc margin. A little hint of it right here. So dish is associated with diabetes. Oh, there was one thing interesting about that film. Let me go back to it real quick. The same patient has terrible cardiac disease. You can see he's got some type of wire here, probably a pacemaker going up into the superior vena cava. That's real typical. Tons of patients have pacemakers. Okay. Chalk stick fractures, they'll often lead to paraplegia if they're thoracic or lumbar. So you see all these things pushing towards like what I'm basically saying. You know, it's all related to the diet. And there's even more to it than what I'm alluding to here, but just to give you the idea. Okay, diffuse idiopathic skeletal hyperostosis is associated with stroke. Okay, it's associated with increased risk of stroke. And here it is. Increased burden of thoracic aortic calcifications. And that's bad too because, you get atherosclerosis throughout the body systemic. And so when dish is present, it's an indicator that the patient probably has systemic Western disease. It's all related. That's what I'm trying to say. The same ischemia that damages the spine is related to the type of diet that also causes atherosclerosis. So that's why you would expect these things to be associated. You'd expect persons who have dish to have more atherosclerosis in the coronaries, more risk of stroke and whatnot, because they're all sort of the same disease. Okay, here's a little more about dish, how it's associated with increased risk of diabetes. Here's another paper on dish. Metabolic derangement is very common with dish. Yeah, because they all have the same cause, so you'd expect them to be related. Okay, so that's it for part 2 of Is It All the Same Disease?